Ginger Ramirez. So this presentation is brought to you by the National Center for Mental Health, the Department of Science and Technology, and the Balik Scientist Program. And she will be presenting uh, her study From Data to Dogs, Exploring Mental Health Innovations for Suicide Prevention and Well-Being. So to formally start our gathering or our learning for today, let us pause for a while and have this doxology or opening prayer.
Here below, praise him above, ye heavenly host. Praise Father, Son, and Holy Ghost. Praise God from whom all blessings flow. Praise him, all creatures here below. Praise him above, ye heavenly hosts. Praise Father, Son, and Holy Ghost. Praise God from whom all blessings flow. Praise him, all creatures here below. Praise him above, ye heavenly hosts. Praise Father, Son, and Holy Ghost. Praise Father, Son, and Holy Ghost.
Okay, so before we have our formal presentation, we would like to have first some ground rules on this virtual meetings. So definitely, we have to choose a quiet location so that we can minimize the background noise and any distraction. Second is, of course, to ensuring that our equipment are working, our microphone, our camera, and our internet connection so that we will be avoid interruption. Be respectful to all participants and avoid interrupting or talking over others. Although kami po ay naka webinar function, so wala talagang makakapag-chat at wala din makapag-open ng microphone unnecessarily. But nonetheless, yeah, keep our microphone muted. You can use our chat function for the question and answer. We will be opening our Q&A box later on so that you can put in the question or maybe share links or provide feedback. But definitely let us avoid using that chat function for general conversation or side chats. So later on po, no, once we acknowledge you for the Q&A, we might be asking you to open your microphone or even your video to ask the question live. And yeah, we can at least have your questions or your comments to the presentation. Okay, so my name is Dr. Rodney Boncajes. I'm the medical specialist for and currently the chief of the Office for Special Concerns. So before we go to Dr. Reyes, who will be providing us the opening remarks, let me give you an overview first of this Balik Scientist program of Dr. Ginger Ramirez. So we recognize that mental health is very integral to every person's health and well-being. And despite its importance, it is often overlooked and stigmatized, leaving those individuals who need care and treatment with limited access to services. So definitely, the pandemic has really affected our lives. We have seen an increase in mental health disorders or conditions, including suicide attempts and deaths from suicide. And despite this, our interventions remains to be limited and our data remains to be scarce. Thus, there is a need or an urgent need for us to establish and analyze information or data to come up with a good information that will be a guide in the implementation of the much needed programs to those population at risk. Uh, because of this, Dr. Ginger Ramirez have worked on his research or his program here in NCMH, focusing on the development of the surveillance system for suicide attempts and self-harm, of or analysis of data related to suicide behavior, and development of a comprehensive report, including suicide deaths, attempts, and the functions of crisis hotline access and others. Piloting animal-assisted intervention such as as an alternative and complementary therapy for mental health. Mental health and sorry, and mental health research, including suicide research, the ethical consideration, the qualitative research method, the scoping, and data analysis. So these are some of the scope of Dr. Ramirez's Balik Scientist program here in NCMH. Okay, so with this, we would like to call on our medical center chief, Dr. Noel V. Reyes, the medical center chief of the National Center for Mental Health, to give us an opening remarks. Doc Ginger, maybe we can grant Dr. Reyes a co-host, sorry po, a co-host status para po makapag-share siya ng video, sorry.
It's loading lang daw.
Yan po, Doc Noel. We can see you clearly po, Doc.
Can you hear me?
Yes, Doc. We can hear you audibly po.
Wala kasi sa monitor ko. Anyway. Hi, good morning everybody. And yeah, good morning everybody. Dr. Rodney, Dr. Mapa, and Dr. Rosena, who I know is online now. And of course, our PCHRD and DOST representative who is attending this exit report presentation. First and foremost, I'd like to express my appreciation to Dr. Ginger Ramirez for choosing this research paper, and also forging the partnership between the DOST Balik Scientist Program and the National Center for Mental Health. As you all know, that the RA 11036 or the Mental Health Act mandates us in terms of coming up with mechanisms for suicide prevention, intervention, and of course response strategies with particular attention to the youth. This is in line with Section 21 of the said law. Now, another one is in Section 29, wherein the law specifically mandates the National Center for Mental Health to expand its research capabilities, for the development of interventions on mental and neurological services in the country. And this is one of the probably initiatives to develop, this intervention in terms of suicide and other forms of program to raise mental health wellness. Later, I think Dr. Ginger will touch on the animal-assisted therapy, and of course, the more important aspect of the paper, which is the surveillance system for suicide. The country are
Yes po, Doc. Sorry po, there has been a
you
technical difficulties. You're on again na po, Doc.
Right. Okay. So, not to mention that, of course, National Center for Mental Health is a very active member of the Philippine Council for Mental Health and its directives. We are instructed to come up with all of these interventions and mechanisms for mental health. So with that, again, let me express my deep appreciation to Dr. Caroline Ginger Ramirez for spearheading this paper. And we hope that this will not be the last and the future collaboration between the Department of Science and Technology and the National Center for Mental Health. And of course, not to mention the PCHRD. Again, good morning, everybody, and thank you.
Maraming salamat po, Dr. Reyes, sa pagpapaunlak ng opening remarks for this activity. Truly po, as mentioned by Dr. Reyes, NCMH being the National Specialty Center for Mental Health is really now going on to some transformation when it comes to research, training and education, and definitely services. And part of our commitment is to forge with other national government agencies and other research institutions in coming up with relevant research and ideas that will improve our services to our Filipino people when it comes to mental health. Again, maraming salamat po, Dr. Reyes. Thank you po. To know more about our speaker for today, I will be calling on the Balik Scientist Program Focal Person for NCMH, or the National Center for Mental Health. He is a medical specialist 3, a psychiatrist, and currently the head as well of the research unit of the Office for Special Concerns. So ladies and gentlemen, let us welcome Dr. Robert Roy K. Mapa.
Good morning, everyone. I have the privilege of introducing our esteemed speaker for this morning. So she is a graduate of Bachelor of Science Management of Applied Chemistry at the Ateneo de Manila University, where she also pursued her degree of Doctor of Medicine and Masters in Business Administration. She pursued a fellowship for health equity at the George Washington University, and likewise completed programs in global health delivery and global health delivery intensive program at the Harvard School of Public Health. She pursued her master's in medical sciences and global health delivery as well at the Harvard Medical School Blavatnik Institute for Global Health. She is a public health leadership fellow of the Ateneo Center for Health Evidence Action Leadership and served as a consultant for health systems management at the provincial government of Northern Samar. She also served as a medical officer for the Health Facility Development Bureau. Currently, she serves as a technical team member for several programs of the World Health Organization Philippines, is a visiting scholar at the Mental Health for All Lab. She is also a co-founder and board member of Community Tales from 2016 until the present, and currently serves as a Balik scientist for the DOST for the Philippine Council for Health Research and Development. So to give her exit presentation, let's all welcome Dr. Caroline May Ginger Ramirez.
Thank you very much, Dr. Rodney, Doc Mapa, and Dr. Reyes. Let me just share my screen. Okay. All right. Okay, so again, good morning, everyone. So again, first of all, I would like to express my sincere gratitude to the National Center for Mental Health for hosting me as Balik Scientist. Thank you for the opportunity to Dr. Noel Reyes, to Dr. Beverly Azucena, Dr. Rodney Pangcajes, Dr. Robert Mapa, and to all the doctors and colleagues I've had the privilege to work with these past months. So first, this is a reminder that I will be talking about suicide attempts, and self-harm, which may be distressing or triggering for some. So please take care of yourselves and of each other. And if you need someone to talk to, below are some crisis numbers or hotlines that you may call if needed. These are the contact information of the NCMH crisis hotline and the Tawag Paglaom hotline in Cebu. So my talk today is basically divided into two parts. First is on data. I will present the work we did in analyzing suicide deaths data in the Philippines, as well as our experience establishing the surveillance system for suicide attempts and self-harm. So it's a pretty long name. I will also be presenting basic preliminary data from the surveillance system and our insights as we are continuously developing this surveillance system. And while data can be fun, the second part is more fun, and I will talk about dogs. I will give an overview of the impact of animal-assisted interventions in mental health and share examples of pilot research projects that we did in NCMH. And lastly, I will provide an overview of other activities that I have completed under the Balik Scientist program. Okay, so I invite you to take a look at this photo. You might see a woman in distress, worried, anxious, afraid of something. You might guess that she's in a crisis and somehow feels trapped. Perhaps many of you are guessing that she might have a mental illness and is having difficulty coping. When we look at the whole picture, however, we see that these two people might be under the table because they're trying to protect themselves from something else, and not from mental distress per se, but from an external threat, an earthquake. So this is classic duck cover and hold. And we see evidence of the earthquake with the items on the floor and the tumblers toppled over. And I actually searched person under the table earthquake to find this image. But if you really think about it, earthquakes and suicides are actually pretty similar. Both earthquakes and suicides cause extreme distress and damage when they happen. And the impact goes beyond a single person. Even for suicides, it affects families, communities, and if they involve celebrities, for example, or some people that are known to many, it can affect even the broader society. Although we know that earthquakes can happen, we still cannot predict the exact time and place that when it will. And the same is true for suicides. Although there are research emerging that can predict suicidal behavior better, suicide is so complex and dynamic that we still do not have a way of accurately predicting if a person will attempt or die by suicide. However, one major difference between earthquakes and suicides is that earthquakes are not preventable, but suicides are. So when you think of earthquakes, we know what to do when that happens. We know the duck cover and hold. We know to grab our go bags and we have done earthquake drills since we were school children. So how come we don't treat suicides with the same level of preparedness, of community awareness, and of focus? So this is my invitation to all of us to think about suicide as probably a difficult and complex issue, but one that is preventable. But I know this is easier said than done. A few months ago, I gave a talk to a room full of guidance counselors and mental health professionals and asked them about why they think suicides are difficult to talk to, why it is kept in the dark. We discussed most common statements or sentiments that they know of that keep persons who are suffering deep down, keeping them in the dark. So we hear these lines a lot. Pinagdaanan din namin yan. Kulang ka lang kasi sa dasal. Sus ako nga eh. Think happy thoughts. Sakit lang yan ng mayaman. Huwag ka nang mag-inarte. These are sentiments of people who might have good intentions, but who may be causing harm. So while today this is not a talk on suicide communication, I have another talk on that. I want to start here to remind us all that suicide is preventable and that each of us has a role to play. We all have a role to address stigma, using our language, using the way we communicate, and we all have a role to shed light on suicide behavior to save lives. We can all do better. And one way to do better is to understand the system. So what happens when a person attempts suicide and dies? When a person dies at the community level, the PNP or the Philippine National Police conduct preliminary investigation to rule out any homicide or criminal act. These are investigations led by the Scene of the Crime Operations or SOCO and logged in their Crime Information Reporting and Analysis System or CRS. So they have their own electronic database. If their preliminary investigation reveals no foul play and if there's the evidence of this being a suicide or accidental event, then the case is now for the health system to record. A doctor needs to certify the death of an individual and issue a death certificate. If a death occurs inside a health facility, the doctor also completes a death certificate that declares this as a suicide. And since the Philippine Statistics Authority or PSA uses the ICD-10 codes, this is recorded as a death due to intentional self-harm. Therefore, when you think of suicide deaths, we have two main sources of data: the PNP SOCO data and the PSA death certificates. But only the PSA death certificate data are considered official deaths data. So what we did in NCMH was to collect and analyze data from these two main sources. PNP data was provided by the SOCO division, and the reports we received revealed 1,412 suspected suicide cases investigated from 2020 to 2023. These were mostly men with a mean age of 37, ranging from 10 to 84. PSA data from 2006 to 2022 was provided by the Vital Statistics Division of PSA. And as mentioned, suicide deaths are recorded as intentional self-harm and classified under ICD codes X60 to X84. So I will show you a few basic graphs, but the rest of the analysis is currently being finalized for publication. So what did we find? In the Philippines, an average of over 2,600 persons died by suicide every year in the past 18 years. So this is annually. We saw a peak in 2020 where more than 4,800 individuals died by suicide, which is roughly equivalent to 13 people dying by suicide daily during the COVID-19 pandemic. And I want us to pause here for a moment and remember that these are individuals. These were persons who were suffering and whose deaths could have been prevented. So we can see the spike during the COVID-19 pandemic in these graphs. The age standardized rates ranges from 2.4 to 4.7, which is pretty much stagnant through the year. So you can see in the right graph, this is data from 2010 to 2022. There was a spike during the COVID pandemic starting in 2020. But here you also see that males, seen in the purple line with a yellow arrow, are disproportionately affected with a peak rate of 7.65 per 100,000. The male to female ratio is 5.47. And for every female who dies by suicide, we see that there are 5 males. PNP data, sorry, the pie chart for some reason is not appearing. PNP data also reveals a similar pattern where over 70% of deaths investigated were male. Suicide also affects young persons. If in the graph, if you look at the green line at the topmost part of the graph, we see that the rates of deaths are highest among Filipinos 20 to 29 years old. And this has been consistent, generally consistent from 2010 to 2022. So again, this is affecting young people. As for geographical distribution, the regions that show the highest rates from 2010 to 2022 are regions 7, CAR, 4B, 11, 10, and 2. And here the PNP, but however here the PNP data shows a different pattern. No, in the PNP data, the bar graph, there are more cases in NCR, region 3, and region 2. So, but in the PNP data, what is interesting, if you can see, is that across all regions, there's a general spike in the light blue bar, which means that there were more reports in 2023 compared to earlier years. So again, the PNP investigates deaths that are happening in the community. So the question is, why are there more deaths happening in the community during this time? Or perhaps there's just improved recording or reporting being conducted by the Philippine National Police. So aside from the population most affected, one data that we looked at are methods. So this is one of the items I was most interested in because a big factor in preventing suicide deaths is limiting their access to means. Our data shows that the most common method in the country, and overwhelmingly so, is in the graph, that solid orange line alone in the middle of the graph, no? The most common method is hanging. And PNP data that we reviewed also reveals the same. So the key question for us is, how do we prevent these deaths? How can we save them from something that's relatively accessible? Before I saw this data, I had no idea what methods were most common in the Philippines. But now knowing this, I think we are in a better position to reconsider, re-strategize our approaches and messaging, especially to the populations who are most affected. So far, I've talked about deaths, no? But what about those people who attempt suicide but who survive, no? When I started doing this work in 2021, I was surprised to find out that we pretty much had no data on suicide attempts in the country. And this was surprising to me because as a doctor, it was standard protocol for us to ask this question to all high-risk patients. You always ask about history of suicide attempts, you ask about the psychiatric history, and really investigate the risk of this individual. And so include that in the management of your patient. So it's not that we don't ask and collect the data. We just don't collect it systematically. We don't record it, report it, and share it. So the World Health Organization developed this practice manual for establishing and maintaining surveillance systems for suicide attempts and self-harm, which aims to gather data from general hospitals. So in 2021, the WHO provided technical assistance to the Department of Health to pilot this system. So I was fortunate enough to be part of those teams who were providing support as well. And now the Department of Health is actually in the process of drafting a policy for its implementation in the DOH hospitals. So here, if you see in the iceberg, no, the top of the iceberg we have are suicide, and these are suicide deaths. So these are the deaths that are recorded in our PNP and PSA data. However, the data below that part are data that we do not collect, the data that are hidden, and we hope that this surveillance system will cover at least the next level so that we have a better understanding of the populations affected and, more importantly, act better in terms of preventing suicide deaths. So the NCMH, as the National Center, as the National Specialty Center for Mental Health, is leading the establishment and institutionalization of the National Surveillance System for Suicide Attempts and Self-Harm, also called SASH. No? So there are 3 S's there. There are 4 S's in that long literal name. So what we celebrate here in establishing the system is that we are collecting data on persons who are still alive, those who have survived an attempt, and those who are already in contact with the health system. So these are people at highest risk, but also they are the most that can benefit from timely, effective interventions that can save lives. So as mentioned earlier, this is a hospital-based system. And while there are recommendations also for community-based systems, maybe that is for the next level, no, of their surveillance. Apart from the usual demographic profile, in the system, we are collecting risk and protective factors as well as the methods. And we will finally have data on methods and on persons who are still alive, no, who do not die after their attempt. So what is the vision? The SASH is a hospital-based surveillance system and is envisioned to be established in all DOH mental health specialty centers. So the NCMH began laying its foundations, and I had the privilege through my stint as Balik scientist to also be part of this. The vision is that the 9 advanced comprehensive specialty centers and 13 basic comprehensive specialty centers will all, contribute to the system so we can have robust data from all over the country. So these specialty centers basically represent the different regions of the country as they are spread out. The aim here is to have an interoperable, is to have this national SASH interoperable with the systems and processes of each hospital, as well as the mental health information system that's underway. So as you can imagine, these different hospitals have their own information systems, have their own protocols, processes, and so just bringing everyone together on agreeing on different data points and agreeing on the processes is something that already is an achievement. And we are pleased that the DOH has drafted an interim policy on the hospital-based SASH in the DOH mental health specialty centers. And hopefully this will even strengthen the implementation in these different hospitals so that we can have a single database for all suicide attempts and self-harm in the country. So let me share some data we've gathered so far. So I won't discuss the data in detail, and but I will give you a glimpse of the insights that we can gain from this kind of surveillance system. So currently, there are already 239 entries to the national SASH. So while most of this is from NCMH, so you can see here more than 61% are is data from the from NCMH, and it's understandable because they had a head start of several months, and most of the cases they receive are psychiatric cases. All other hospitals also attend to general cases, and most of their cases are general. No, so for NCMH, they began the program early last year, really understanding more the internal processes. And one of the things that actually helped the NCMH in implementing this system is that there was very strong internal commitment, not only with a single office. No, so this is something that was implemented in partnership, in collaboration with different offices such as the emergency section, the office for special concerns, of course, outpatient department, and even the medical record section. It was very important for us to get approval of the medical record section of the form so that this is something that can be official within the hospital. So I was involved in the training of the ACCs and the BCCs, also in the establishment of their own systems. And there, as of this week, 9 out of the 22 have activated their internal processes to collect this data. So, and we consider this as a win, especially since actually the hospitals started actively engaging just this year, just in 2025. So the 9 hospitals that you see here, the earliest here started in January, but most of these actually started February and March. So we are on the right track, and hopefully this will continue. So we see in the preliminary data that we have that the suicide attempts and self-harm primarily affects the youth. So this is similar to the data that we saw in the deaths data. But here they are younger. So we see that the highest numbers are in the adolescent years, 15 to 19. So if you remember earlier, the deaths were more common in the 20-year-old youth. But now, but here we see that the attempts happen when they're younger. So if you're able to address them when they're younger years, perhaps we can prevent those deaths when they turn 20s. When they enter their 20s. We are proud to share that we have data not only on sex, but also on gender identity and sexual orientation. Since persons who identify as part of a gender and sexual minority are 2 to 5 times more at risk of suicide. So we want to have a better profiling of this vulnerable population because the programs that will be provided for them may need specialized or more tailor-fit interventions. No? And here, if you look at the sex assigned at birth, we see that there are more women attempting suicide. And this is in contrast with the earlier data that I showed you, where there are more men dying by suicide. So this pattern is actually similar to the pattern in different countries, where more men die, but more women attempt. And the deaths in men could be attributed to men using more lethal means, or because they're able to access support and care later. No, so the access to care is delayed. Most of the cases that we saw also were of individuals who are single and Roman Catholic. So 87% are single, and majority are Roman Catholic. So one of my personal hopes here is that, or maybe the question that we can ask ourselves is, how can we engage the Roman Catholic Church? How can we engage religious groups in preventing suicides? Because we know that religion is pretty important here in the Philippines, especially since over 80% of Filipinos identify as Roman Catholic. Since we are in the advocacy of saving lives and making wellness or well-being more accessible, religion and faith are fundamental to this. So how can we engage these institutions better? In the surveillance system, we also ask them if this is the first time that they attempt, because the highest risk factor for a suicide death is actually a previous suicide attempt. So this is the first time we will have data on index attempts as well as repeat attempts. And so far, our data shows that 65% have had previous attempts and now are at higher risk. One interesting finding is that when we asked about the place where they attempted, the majority mentioned that these attempts happened at home. So information like this tells us that prevention interventions should involve family and household members. They are crucial to saving lives because this is where the distress happens, the suffering happens, but this is also where the most significant levels of care and support can happen. We also asked if they've previously received professional help. Half have, but haven't. So this may reflect limitations of accessing mental health services, especially since in the previous slide, if you remember, I showed that 65% have a previous attempt. So we don't know if the 65% of people were also the ones who have sought professional care. But in addition, for those who have previously received care but who still are exhibiting suicidal behavior, this information can provide insight about the care that they're receiving. Are there concerns about access? Are there concerns about the techniques and strategies that might be most helpful for them? So again, the question is, how can we support these individuals better? And are there barriers to access that we need to prioritize? This is the first time the country will have data on methods among persons who are alive. So we are using the ICD-10 codes as well to match the data on deaths as well as international standards. So, and knowing the most common methods helps us think more strategically about how to act towards saving lives. So for self-harm, the most common are the use of sharp objects, hanging and jumping. But again, since these are actually very difficult methods to prevent. So we have to start thinking about how to more strategically think of prevention, now targeting our interventions towards these methods. For self-poisoning, we see that the most common agents are medications. So the questions are why, where, and how do these individuals access these agents? So we have anti-epileptic, sedative hypnotic drugs, non-opioid analgesics, and other drugs, no? So are these persons diagnosed with other conditions? Why do they have access to a lot of drugs? Do they buy medications in bulk? And again, how do we limit their access to potential harm? The other important thing I want to point here is that in terms of classification, so we're happy here that we always include an open text option in the form, so that if they don't know the classification, they can also put there the different agents that are used. So this has been very helpful for us to really have a better insight of the behavior of our of these individuals and how we can again prevent their suicide attempts and deaths. And lastly, disposition. So what happens to them when they enter the hospital? They are provided care, and what happens to them after they receive care in the hospital? So I find it interesting that more than half refused admission. And the question is why? No, that's at the bottom of the graph. You can see 111. So why are they refusing admission? Is it because of financial barriers? Are there other social cultural factors? Is it stigma? Is it the quality of healthcare that they receive? So I know I am presenting more questions than answers, but these initial data helps us understand the situation better so that we can towards addressing this very complex and important public health issue of suicide. So I want to share several considerations and challenges that we've learned while we were working on this. So first is the varying levels of maturity in health information systems of the different hospitals. So although our initial goal was to incorporate this into electronic medical records, almost all of the hospitals have decided to use paper forms because electronic medical records and other digital information systems are still under development. So right now we are collecting this data through Google Forms. And while this is great because Google Forms are very accessible, we need to work towards a single vision for a mental health information system that will be more accessible and sustainable, and that will ensure high quality data management. Second is ethics and data privacy. While we do not collect personally identifiable data, this is something that should be assured and protected at all levels of the system. So we, again, will be sharing data across different hospitals and across the country. So we have to make sure that at the end of the day, these systems protect individual people. And the third thing that I want to share with you, which I personally think is one of the most important considerations, is that the issue on insurance claims, liability, and access to benefits. So we discovered that if we begin collecting and recording data on suicide attempts and self-harm, and include this data in official, like formal patient charts, this is something that insurance companies might use as a basis for denying claims, or employers using it for denying benefits. So even when we reviewed the amended insurance code of 2012, it actually specifies there in the code that persons can be compensated only if there is an established, and I quote, state of insanity. So obviously there's something that we need to change in the language and in the policies, and it's high time that we address this. And this is not something that we can just talk about. No, we need real solid policies to shift our system so that we can protect individuals. So if we will do this well, if we will do surveillance, if we will do suicide prevention work well, we need new policies that will protect individuals and their families, and not have them being restricted from the resources and help that they need. So I hope that this is something that our leaders can prioritize, something that we can work on, because at the end of the day, stigma is still very strong, and that stigma is actually embedded in a lot of our policies. The hope is to institutionalize the SASH and NCMH and all DOH mental health specialty centers. NCMH is committed to this endeavor, and we hope that in partnership with the Department of Health, Mental Health Division, Epidemiology Bureau, and that this is something that can be used for national level policy making to guide the DOH and the Philippine Council for Mental Health. So again, this is the first time we're collecting systematic data on suicide attempts and self-harm, and this will really give us more information that can help us prevent deaths. No, and I encourage us to work on this now while we are not in a state of really intense crisis, because when intense crisis comes, it's very difficult to set up these systems. But gathering and analyzing data is only the beginning. No, our real goal is to convert these insights into actions that can directly lead to improving and saving lives. So zero should be our only goal for suicide prevention, because one death is too many. And let us together work towards this number, and each of us have a role. Sometimes I think that I might be one of the, I don't know, few people who has this much enthusiasm talking about suicide prevention in the country. It is because almost 20 years ago, I found myself in that dark place, hunched up and alone. So this is also my personal story. And this is my story of hope, where one person reached out to me at the right time and place, and she literally saved my life that day. And I share this with you, even if this is still this is quite uncomfortable for me still, no? And I share this with you because as a reminder that we don't really know what people are going through or have gone through, but each of us can play a role in saving lives. So whether it's establishing a system, it's creating policies, or being a kind and compassionate person to a friend, we and all save lives. And here's where I shift to the part about dogs. So I am one of the co-founders of Communitales, one of the leading providers of animal-assisted interventions in the Philippines, founded by Dr. Carla Azucena, with her therapy dog, Bubu. So here is Carla and Bubu. So they are the first human-animal teams that we had in Communitales. So for those who are not aware, NCMH is one of the few health institutions, if not the only, it's probably the only, no, health institutions that is exploring animal-assisted interventions for mental health care. Now, this is in the country. As early as 2018, NCMH had their in-house therapy dog, Yogurt. So that's Yogurt. You see, Yogurt was even given his ID and put under the chief resident tag in the training office. So this happened even before the pandemic, and I'm glad that now after the pandemic, the NCMH is continually expanding the research in this very new field. But before we explore further, so why animals in mental health? Human-animal interactions are more than being around cute dogs and cats or other animals. Animals have been shown to impact us not only at that have been shown to impact us at the physiological level, with research showing decreases in stress, anxiety, and depression scores. There is an increase in oxytocin when we interact with animals, and actually decrease in cortisol levels. And this is true for therapy animals as well as companion animals at home. And this research and research has shown this to be effective for persons also with experience of trauma, such as veterans and survivors of abuse. Animals offer a calming effect and are sometimes helpful distractions to stress. So in group sessions that I've done, participants bring so much the therapy dogs bring so much joy to the circle, but it also adds a lot of calmness and groundedness. So being able to touch the dog's fur or hug a live floof ball can help with emotion regulation. And this is something that we've seen in our work. The animals are also social catalysts that enhance learning and foster social communication and interaction. So even if the animals don't speak our language, there's much we can learn in communicating with them. And it encourages us humans to communicate with each other when we talk about an animal. Animals also offer social or emotional support in addressing loneliness and isolation. And being with companion animals lower blood pressure, heart rate, and increase overall brain health, presenting with a 40% lower risk of dementia. So if you want to improve your brain health, you can use it as an excuse to get a pet or interact with more animals. And lastly, I know this is going to be a very unscientific thing to say, but animals really do have their magic. So we've had several experience in Communitales when a dog approaches a participant and without us knowing why, and even only after the dog approaches and the person shares do we find out that this person is actually going through something difficult. So we were not aware of what was happening to this person, but the dog already knew and was already immediately approached these individuals needing that additional care and support. So animal-assisted interventions, or AAI, are goal-oriented and structured interventions that intentionally include or incorporate animals in health, education, and human services for the purpose of therapeutic gains in animals. So it will the therapy is for the humans, but we involve animals in the care. And this field of animal-assisted interventions is backed by the science of the human-animal bond. So there are three categories under AAI. We have animal-assisted treatment or therapy, that's AAT. We have animal-assisted education and animal-assisted support programs or activities. So the main differences here is that AAT, or animal-assisted treatment or therapy, they're structured and therapeutic in its design. And the goals here include physical, cognitive, behavioral, and socio-emotional functioning. And this is delivered by a licensed professional or credentialed professional. So this is more formal structured intervention. AAE is for education. It's for improving academic goals, pro-social skills, and cognitive functioning, and usually delivered by a education professional. And AASP, or animal-assisted activities, are unstructured activities that offer recreational or supportive care. And so this is likely what you see online when you see dogs visiting hospitals or care homes. And even if it's unstructured and the dogs go walk the hallways to visit, that in itself actually improves mental health care. So in communities, our teams are called HATs, or human animal teams. And this is composed of a trained and certified handler and human. Trained and certified handler, that's the human. We have the animal, and they are both supported by a steward. So our HATs are the service providers of our interventions. And in communities, one of the most common questions that we get is what breeds can be therapy dogs? Because people are interested to get their own therapy dogs. So in communities, currently you only have dogs, you don't have any cats, no? So this is a common question, what breeds? But the answer to this question is that any breed of dog can be a therapy dog, but not all dogs are meant for therapy work. So you can have a golden retriever, which is a classic image of a therapy dog that might not be appropriate for therapy work. Or another, or even an Aspen is perfect for therapy work. So it's not dependent on the breed at all. And it is mostly dependent on the temperament of the animal. And here I just also wanted to show you, here are some of our therapy dogs through the years. And some of them have already retired or have crossed the rainbow bridge. But I hope like even just seeing their faces in the screen already brings a smile to your face. It's a privilege to work with them. So what is the ideal therapy dog? The ideal therapy dog has the appropriate temperament and loves interacting with different humans in varying situations. So it's crucial that they love it and not just tolerate it. And they are healthy and cleared for work by their vets and have basic obedience skills. So I don't have enough time, but if you want to learn more, we actually have an ongoing training right now. If you want to join, we might still be able to accommodate you. So I'd like to share with you the research of one of my research mentees, Dr. Olive Reyes, who I think also is joining us this morning. Hi, Olive. And her research is on the impact of AAT on functional outcomes of patients with chronic schizophrenia. So this is the first in NCMH, I think first in the country, and where we incorporated animals in the care of patients with chronic schizophrenia who are admitted in NCMH. So Olive assessed functional outcomes, and the goal here was to recruit 10 males and 10 females. So we had two different groups, and each group completed 8 sessions. And for each sessions, there was a general structure of an activity where the participants interacted with each other and interacted most especially with the human-animal teams. So the measures that Olive used are the following: the Montreal Cognitive Assessment, which measures global cognitive function. So that's the MOCA-P. Second, we have the chair stand test. And this chair stand test measures lower body strength. So I'll show you a video of that in a bit. And the time up and go, which measures agility. And lastly, we also use the measure on the human-animal interaction scale to also determine if there were any changes in how the participants and how the patients were interacting with the therapy dog across the 8 sessions. So one of the key learnings that we gathered through this research is the importance of equipping human-animal teams. No, as mentioned, we have training, but that's standard. But here we had to ensure that the teams are also trained at mental health care and specifically about schizophrenia. So most of the hats and stewards are not medical or mental health professionals, but they bring in their expertise as human-animal teams and stewards. They bring in their expertise in the human-animal bond. So we highlight the importance of having adequate orientation, exposure, and pilot runs. So we actually had to practice the activities a lot. We had to place the animals where the patients might be walking to see how the dogs will interact with the people who are moving. And we also asked some volunteers, so other residents, to act as actors, to pretend to walk and behave like patients with schizophrenia, since their behavior might be different from what the therapy dogs might typically be used to. So we had to make sure that we tried this and practice and pilot. Number one, because it's ethical practice for the humans, but also number two, to ensure animal welfare for our dogs. No, this simulations help us learn a lot about how we can make it more efficient and safe for everyone in the room. Here are just some videos for us to enjoy. But the basic session that Olive had was lasted for about an hour to hour and a half. And the participants began with a warm-up period where there are greetings and introductions. And this is usually the time when they have informal interactions with the dog and the hat. So here, you see two of our therapy dogs. They have Santi enjoying a lot of back rubs and head rubs. And also at the bottom, you see one of the patients brushing Santi. So this is something that could is calming for Santi, but also calming for the patients who are doing this for him. We also see Lexi receiving so many head rubs as well. So despite being so small, Lexi was being handled very gently by these participants, and like Lexi is in the middle of a group of 10 really big men, but she was just very calm and was happy to receive all of the love from the participants. So one of the tests that Olive did was a chair stand test. This is a performance-based test where the participant will rise from a sitting position to a full standing position with arms folded across the chest. This is timed for 30 seconds, and the higher the score, that means the patient has better lower body strength. So here, there is the dog in the room, but there's really no direct interaction with the patient. And the other test is the timed up and go test. It's just another performance-based test where the participant stands up from a chair, walks a certain distance, a set distance, walks around a chair and sits down. So that's why it's timed up and go. And the time here, it is measured in seconds. And so that if the score is lower, that means that the patient has better agility. So one way that we incorporated the dog here in the specific exercise is that instead of just walking from one chair to the other, we made sure that the dog was in the other chair, so that the participants the patients, after they sit down, they get to pet the dog and to give a treat to the dog. Which might have encouraged like motivation and just something that was more enjoyable for the patient. So we see this in the video where this particular patient goes around, sits down, is given a treat, and gets to feed Santi. So everyone's happy, especially Santi. Okay, so what were the findings of Olive's research? So the initial recruitment was 20. We have 10 males and 10 females, but unfortunately, we had a pretty high dropout of 35%. But the dropouts are because these patients were sent home. No, they were actually reintegrated into their families and communities. So while we were sad that was dropouts on our end, we were happy that they were reintegrated with their families. So a series of linear mixed effects model analysis was done to answer the hypothesis question here presented by Olive. And I just want to share this one analysis. There are other analysis, no, but here in this analysis, we did the ANOVA. We see that there's some improvement, no, in the lower body strength, agility, cognitive ability, and social emotional interaction across the different participants. So this was just a measure from session 1 and session 8, no? But this is not really there were a lot of limitations in this study. Number one, because of the small sample size. Number two, because of the large dropout also. But I think for Olive's research, it was more than the results. What we learned really is the operationalization of a research project, the training, the preparation, the documentation, the prep, and the debriefing that happened after the what to do if there are incidents, how to ensure that we take care of both the humans and the animals. So that was to me the more important aspect of the learning. And the lessons that we got from Olive's research, actually we convert directly to this other project that is also led by the National Center for Mental Health. So this was, I think, mentioned. The NCMH is the implementing agency of a DOST funded project entitled Project PATS. So PATS stands for Pioneering Animal Assisted Therapy for Female Adolescent Trauma Survivors in the Philippines. So it's very long, but it's PATS. So basically here, this is a partnership between NCMH as the implementing agency and communities as the implementing partner to provide the human-animal teams and the expertise in offering animal-assisted interventions. So this is a funded research project by the DOST, Philippine Council for Health Research and Development. And then, so the objectives of Project PATS is to measure the effectiveness of animal-assisted therapy and the treatment of female adolescents with a history of abuse and trauma, and to describe the barriers and facilitating factors implementation. So we are actually in the middle of the project. So we are recruiting 12 participants, 12 to 17 years old, who are currently staying in shelters, no, whether these are LGU or DSWD shelters, and their sample is 117 participants. So we actually just started the sessions this March, and hopefully will be ongoing for until July or up to October, no? So these young adolescents will be going through a group intervention of 8 sessions. And here, what is different, and I guess a little bit more advanced, no, is that we will have 3 arms, a control arm and 2 intervention arms. So one of the outputs of this research is to have a manual for delivering this group intervention. So the lessons that we learned from Olive's research and that implementation, combined also with the lessons from Project PATS, will give us more insight on how to put structure, to how to provide specific guidelines and manuals for delivering animal-assisted intervention services and conducting animal-assisted intervention research. Okay, so basically the Balik Scientist program has provided me a lot of opportunities, and I was also blessed to have been selected to be one of the presenters during the PSP annual convention last year, November of last year. I'm also currently part of the board of the Balik Scientist Society of the Philippines as a representative of the PCHRD, and this is the inaugural board of the BSSP, no? So looking forward to more activities of the BSP and to encourage more scholars, more scientists to join the BSP. Just some a summary of the lectures and seminars that I've been able to conduct through this BSP program. So a lot of them are related to suicide prevention, as you probably would guess now. So we did formal forums with and trainings, lectures with professionals such as psychiatrists. I gave a talk to guidance counselors for developing protocols for suicide prevention in schools, a lay forum as well, which was conducted online, and presenting of the research on Filipino suicide behavior of Filipino adolescents. In terms of trainings, again, we had trainings related to the SASH, the establishment of the SASH, and providing considerations for suicide prevention and safety planning for frontliners. And of course, also conducting a lecture or a training on how to conduct suicide prevention research, because it is pretty difficult to conduct suicide prevention research as well. In terms of policy development, we have contributed to the National Suicide Prevention Strategy and the guidelines for the implementation of the SASH, as well as the review of indicators of the PCMH strategic plan. With collaborations and linkages. So for the PATS projects, we actually have partners already. Currently, we have 9 shelters partners, and these are formal partnerships with MOU signed between the different institutions for a research collaboration for animal-assisted therapy. Also completed a research in partnership with the Harvard School of Public Health. So this was in analyzing child and adolescent mental health in the Western Pacific region. So that also should be published in a few months. And we are in conversation with another Balik scientist, Dr. Cruz of the University of North Carolina, and Dr. Truls of Duke University. So these are still programs that are to be realized, no? Just the overview. So we are planning to publish at least 3 publications. So the first is already in with the Lancet Western Pacific region for review. So this is we contributed as one of the countries in that scoping review. And then the publication for the suicide deaths and suicide attempts, that is something that we are working on right now. We also engage in like training and in basically mentoring of other psychiatrist trainees and the team members of PATS and in the Office for Special Concerns. So basically, what are my plans after BSP engagement? The goal is to continue working with NCMH, no? And because NCMH is such in a unique position to really do something in terms of mental health care provision in the Philippines. So there's no other institution that is like NCMH, no? And that it really has a very unique and distinct role in providing not only clinical interventions, but providing public health leadership and interventions as well. We have to publish the research that we did, and currently, actually, we are developing a capsule proposal for submission to the DOST, expanding, so exploring digital technology. So now that we have a better understanding of the situation, what can we do to prevent these suicide deaths? Thinking more of interventions of care and maximizing the crisis hotline data. And how do we want to expand animal-assisted services? Of course, we will complete PATS in the next few months. The NCMH also would like to explore employee wellness, so incorporating animals for workplace wellness. So for those here or from NCMH, looking forward to having dogs in the workplace, no? And perhaps also incorporating arts, no? So animals and arts, these are complementary interventions that can be added to traditional mental health care. Okay, so that's an overview. I'd like to thank all of you for giving me the opportunity to share with you. I'm sorry, the last slide is not showing. Okay, sorry. Last slide. Okay, last slide. So anyway, thank you very much. Thank you for listening to my talk. And again, thank you very much to the National Center for Mental Health for this opportunity. And I'm looking forward to continuing the work with everyone. Thank you.
Okay, thank you, Doc Ginger. That was really very informative, no? Kung titingnan natin, baka information overload dahil daming na-share ni Dr. Ginger. Pero definitely these things are not, she tried to compress it in a one presentation. But all of this effort has been undergone in a several months. Ang daming effort po, ang daming time na Google for this. Aside from being a balik scientist, Doc Ginger has been also a partner of NCMH in providing guidance to residents, our psychiatric residents in training for their research. You know, as you can see, they have already or she have already shared one presented by Dr. Olive Reyes. But I think there are other research that Dr. Ginger is one of the mentors for our residents or teaching our training residents. Sige. We are now encouraging everyone to use the Q&A button as we now proceed to our open forum. If you do have questions, clarifications, comments, or something that you would like to share in this presentation, kindly do so. We can allow you to open the microphone if that would be necessary kung gusto niyo na magtanong ng directly. But you can use the Q&A button po, no? But I think some of the participants are using as well the chat button. Pero sige, wala din naman pong problema. Baka kasi some of you are attending using the phone and it might be more handy for you to use the chat button. So, sige po, no? Let's go to the Q&A, Doc Ginger. So, ako po magbabasa, kayo po ang sasagot. So, we have from anonymous attendee. Thank you, Dr. Ginger, for this presentation. May I ask, are there existing research in the country regarding pet ownership among suicidal attempt survivors? Would having pets be a viable companionship option, especially for those with no or limited social support, such as family and friends?
Okay, thank you very much, Doc, and thank you for that question. No, so I personally am not aware of any research regarding pet ownership among persons who have suicide attempt, a previous suicide attempt. And your question for if they are viable companions, I think there are like two ways to answer this question. So number one, it is clear that having animals no can benefit mental health, and I think for all the pet owners here, you already understand what that means, no. But for persons who are suffering from different mental health conditions or are even suicidal, we also have to take note that apart from thinking of the human's well-being, we also have to consider animal welfare. So if will having, for example, a new pet, will that increase comfort and care, or that may also be a source of additional stress, especially if there are limited support mechanisms. So for example, we know that having a pet can be very expensive and can require a lot of care. So if the person does not have that capacity, then it might not be the best for that individual to have a pet as well. So we always, so in communities, one of our tagline is for like mutual healing. So you always think of both entities. We think of the human, considering human well-being, but also consider animal welfare. So if this is good for the human, we always consider, is this also beneficial for the animal? Because if it is something that will be harmful for the animal, then it is something that we should reconsider. I guess it is also an invitation to the psychiatrists and other mental health professionals listening now to also kind of be careful about prescribing animals to patients, no? And this prescribing emotional support animals or for getting pets. So let us ask about the patient's ability to also care for these animals so that it can be the healing and the caring can go both ways.
Yes, so ito po, no, tama siya, si Doc Ginger. So when it comes to us, no, psychiatrists who are somehow or being asked to provide certification ano yun, sa animal as companions, international travel, we have to take note of what Doc Ginger has mentioned kasi importante po na maintindihan din natin ano yung mas makabubuti hindi lang doon sa ating service user or doon sa patient na nagre-request but also to the pet as well because we consider both lives here. Okay? So before I go to Dr. To to Rohani Navarro. There's a question from the chat box. I'm looking on the time po kasi kung kailan nila pinost. So si Sir Richie muna from Mental Health Program Division. So moving forward, how do you see the PATS project as a possible sustainable intervention to manage mental health or psychosocial concerns nationwide, both among facilities and maybe as part of the community-based mental health interventions?
Okay, hello Richie, thank you. Okay, so as I mentioned, we're like in the middle of the of PATS, no. So it's 8 sessions. We're still in session 2, so we just started, no. So but our goal really is for this to be expanded. So what can that look like? So right now we are working with shelters. So we are working with they're providing the service to the most vulnerable of individuals. These are young female adolescents who are living in shelters, who have a lot of history of trauma. And the most common cases that we see there are cases of sexual abuse, no? So being able to provide them a psychosocial support service is already very beneficial. So in the PATS, the goal is to have a manual, no? So what we put in the manual are the interventions with the dog and interventions even without the dog. So the manual will actually include the modules, even if you don't have a dog, because that's the control arm. So one of the things that we're happy about is that even if facilities are not able to provide the dogs, then at least they can use the no dog version. But in terms of incorporating the animals there, some of the requirements would really be having these human animal teams. So training is very important, and training in terms, again, because we're sanay tayo na we're thinking of human welfare, which is great, which is amazing, no? But we always have to think of them, consider them side by side, kung makakatulong ba din sa animals. And that entails a lot of training, a lot of exposure, and sometimes shift in the policies of these institutions, no? So facility-based animals, yes, that is a possibility. But in the Philippines, medyo we have to improve pa, medyo mataas pa yung level natin ng stigma. A lot of people are afraid, no, of dogs, which is, valid. But there really is a lot of kind of institutional change that needs to happen. But if you are an institution, let's say you run an institution that's progressive, you want to explore this, there are policies that we can set up so that we can prioritize safety and we're able to deliver services. So sa NCMH, parang ganyan. So NCMH wants to deliver this. So slowly, we're training people, we're putting all of these policies together so that we can provide a space, especially in the workplace or even at the committee setting, that will be healthy for both the humans and the animals.
Okay, thank you, Richie. So definitely, we have to take into considerations many things, but again, as mentioned by Dr. Ginger, this can be applicable eventually. We have to come up with relevant policies and definitely on the magiging outcome or magiging output nung project, we can make some recommendations from it and tailor fit it if it is possible to really be incorporated as well in other hospitals or facilities and even in the community. But yeah, we have to continue the study muna, no? I think nasa gitna na yata tayo, Doc Ginger, nung sa PATS, or patapos na ba tayo dun sa PATS?
Sisimula pa lang, Doc.
Nagsisimula pa lang. Yun, nagsisimula pa lang naman. Pero it's a good thing that we're looking on the possible incorporation of this innovative program dun sa community at sa other hospital. Okay? So from Rohani Navarro, hi Ginger, I have 2 questions. One, in the Philippine data on suicide that you showed earlier, do you have the data about the typical income profile of individuals who die by suicide? I wonder if suicide risk can be associated with income levels. And second, are there sex differences on responses to AAT in the schizophrenia study?
Thanks, Honey. Okay, thanks, Doc. So number one, in terms of the data on deaths, so we did not see any data on deaths that include income profile. So I don't think PSA collects this because this is data that they collect from the death certificate. So that's not included as one of the items in the death certificate that they can tag in the PSA data, no. But in the surveillance system, one way for us to kind of measure this is to, but we're collecting what they call this, employment and education. So that's probably one way of also considering income profile, but there's no specific data on income profile for both the deaths data and the attempts data. But internationally, there are people do study this, and we kind of anticipate that it is probably more common in lower income individuals, mostly because they have less access to care. No, but yeah, this is definitely an area of research. And then in terms of the number two question, the sex differences. So for Olive study, it was a very small, and then there was very high dropout because they were all sent home. So many participants were sent home. So yeah, we did not see any parang viable analysis there, but hopefully nga in the future studies, we can evaluate that.
Okay, sige po. As mentioned, no, marami pa pong opportunity for this, no. The important thing is that we have already started, but definitely come along the way, we will be able to answer those concerns eventually, no, as we progress dun sa mga studies natin. So thank you very much. From Raquel Braceros, Doc Ginger, what challenges have you encountered considering the limited number of therapy dogs or animal use in sessions or visits? And thank you.
Thank you. Thank you, Raquel. Yes, it is very challenging. The limited number of therapy dogs is very challenging. To be honest, mahirap siya. Mahirap to kind of like recruit these therapy animals, and of course the handlers as well, no? A lot of people come to us and they say, no, oh, I want my dog to be a therapy dog. And then they go through the training. But there's also a screening that happens after the training. So it breaks our hearts sometimes when they go to the screening, and then through the screening we determine that their dogs are not parang most appropriate for therapy work. And that's really difficult. So I don't remember the numbers now, but I don't have the numbers now, but yeah, in terms of parang the pass rate and the parang not appropriate rate, medyo ano siya, medyo mahirap. But so this just means that we have to also expand, no, and invite more people to train and understand what it's like, and to work together with their dogs so that they can work really as a team. Sobrang crucial nung teamwork between the handler and the therapy dog. But yeah, so challenges in terms of recruiting, training, the human-animal teams. And this is just not training ng simple lang. The participant, our human-animal teams, the community health teams have gone through a lot of training the past week. So when they did the training, we also had the research kasi with trauma survivors. So all of the community health team, they underwent trauma-informed care training. We did simulations, we did live workshops. So there's a lot of training involved, and one of our objectives actually is to really push for the professionalization of animal assisted services in the country. So hindi lang siya, although it's cute and it's fun, behind all that cute and fun are a lot of safety protocols, a lot of credentials, because we want to make sure that everyone is having a good time, and we don't want to put anyone at risk. But yes, it is kind of hard. So please train, and let's all expand the services more. Yeah.
Yes, thank you, Doc, no. Raquel do have another question, but as mentioned, no, medyo ako dun sa time kung kailan sila nagtanong. So may sumingit muna na isa. So from Manda Guillam, what are the key considerations for exploring the potential for animal-assisted therapy in a hospital setting? As mentioned by Doc Ginger, no, maraming mga factors, including the availability of the resources, including the human-animal team. Pero other than that, Doc, what can be the other potential what are the other key considerations in exploring this and being this applied in the hospital setting?
Yeah, thank you for that. No, so actually one of my outputs here as Balik scientist is to draft um um proposed guidelines for conducting animal assisted interventions in hospital setting. So exactly what you mentioned, no, was one of my outputs. So hospitals are pretty different from other settings, primarily because that's where sick people are, no? So we have to, the number one concern is probably infection control and safety, because we of course do not want to spread any diseases. And at the end of the day, the animals are animals and they have a different biological profile. So safety is slightly different when it comes to hospitals, because we have to have even much higher standards of care, particularly in terms of infection prevention and control, no? However, with working with hospitals, it can also be more rewarding, because that is where patients need the most care and support, no? So when the dogs walk the halls of the hospital, it's good not only for the patients but also for the staff. We've been trying to figure out how to partner with hospitals, the patients, in a more like systematic way. But with the research that Olive did, this is actually, I think, like the first research talaga that interacted, that where we had a program na they were interacting directly with patients. So yes, there are a lot of considerations. Let me give just one more example of a consideration in terms of equipment. So ang dami equipment sa hospital, 'di ba? You have magro-roll ka ng yung mga carts, yung mga lalagyan ng IV, rolling of, like X-ray. People are walking so fast, ganyan. So that the therapy dogs in that setting will have to be used to that kind of context. It's different if you're going to a school or if you're going to a workplace, kasi ibang-iba yung environmental setting. So those are just some examples. Thank you.
Yan, okay. So, other than that, Doc, of course, another question from Raquel is, what can you suggest us, or yeah, what can you suggest us working at school in introducing animals as aid helping students on their mental health? What initial step can we do? And we can just introduce it without certified therapy dogs, or that's just a question, no? Pwede ba sila mag-introduce ng animal without being the therapy dogs certified, something like that po?
Yeah. So actually, ang number one na nag-approach sa communities or schools. So what happens is the guidance office or the school personnel who are focused on mental health, sila talaga yung parang number one stakeholder. So if you want to, like, I guess, go to school, they're the people to go to. So yeah, I would suggest going to the professionals in that school who are most invested in mental health, in providing that for their students, and also who know about the population. So when we were working with a school, and previously when we were working with one school, we were just offering services to general students. But at some point they requested, na can we have a more targeted session that's for a particular high risk population. So these are and then so we had a collaborative project wherein the guidance counselors were selecting or screening these high risk students. So they might have, maybe other diagnosis, or, have incidents of, whatever. Basta sila na nag-screen and nag-select ng mga participants, and we provided that. So working closely with the guidance office, for us, has been very beneficial, because kilala na nila rin kung sino yung best na makakapag benefit from animal assisted interventions within their school. One important consideration in schools, though, is that everything, of course, has to we have to get the consent of the parents and the guardians. So for us in communities, we always have a waiver, we always have an informed consent. So even if it's an interaction of like 15 minutes, everyone has to sign something, no? Again, we are medyo ok in terms of safety, in terms of like consent, because we really, at the end of the day, they're animals, and we cannot exactly manage or like treat them in the same way as we do humans. So we humans are the ones who need to put these extra protocols so that they're safe and that the humans are safe as well.
Doc, yung tanong na parang pwede bang mag-introduce sa school na hindi siya certified therapy dog? Is it possible?
Well, 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 technically it's possible if you want. Parang wala namang pipigil sa'yo. But of course, yun, we want to ensure again animal welfare and human well-being. And the base of that is always safety, diba? So, yun lang yung isang consideration if like these dogs don't have the appropriate temperament, if they're not ready, if they don't enjoy it, then at some point it will show in their behavior. And if they're upset, if they're distressed, at any time an incident can happen, 'di ba? Because they're distressed. So responsibility natin na hindi sila ma-stress. Kasi pag ma-stress sila, they're gonna behave as a regular animal would, no? So I guess as long as there's appropriate training, exposure, orientation, and really collaboration with your partners, then of course it's a good thing, no? We don't want to restrict din naman, but just make sure that the safety precautions are there.
Okay, thank you, Doc. So I think itong susunod na tanong, Doc, somehow ay baka related din siya, no? Kasi it has something to do with the dogs pa rin. So, ayun, Doc. From Daniel Marie Pareno or Pareno. Hello, Dr. Ginger. Thank you for the really informative session. Since you mentioned animal welfare, I am wondering what your thoughts are in partnering with community animals, especially yung mga aspid na nakatira sa streets as part ng AAS.
Yes, thank you, and then so this is something that actually Communities has been exploring even since the beginning of time, no. So it was one of the hopes before was to really work with aspens, and not just aspen but also like rescue dogs. One of the challenges lang that we had there, because just mentioning lang the rescue dogs first, is that they also have their own trauma. So we have to like focus on that first. Because if they have their own trauma and they don't enjoy the interactions, then we were re-traumatizing them. It's not good for animal welfare, no. So that was one of our major considerations. Even if like they enjoy, pero dahil nasa-stress din sila dun sa interaction, syempre hindi natin gusto yon, no. So I would say that it's very important to always evaluate the appropriateness of the animal, no? So again, temperament. At kung enjoy ba talaga niya. When we do our screening, you can see sino yung talagang, oh my God, I'm so happy to be here. Yung mga dogs na ganon, meron talaga Ibang-iba siya. At makikita mo siya, like how they interact. And not just with select group of people, parang with anyone. They're always happy to meet, interact, and they really enjoy it. You can see it and in their behavior, in their body language. So if your dog is not like that, then it will be hard for them, because these are actually working dogs. It's their job to do this. So I mean, just like us, if you don't enjoy your work, then it's not gonna be it's gonna be a chore, So I guess that's one. But in terms of really working with community animals, I would suggest to like if you have like a group or community who are supporting animals, we don't have to make everyone a therapy dog din naman, no. And not all, I mean, and then there's this, like, I think there are like memes online, diba, na parang all dogs are therapy animals, others are just parang freelancing, na ganon. And I think that's true, because we people who have experience with companion animals, gets natin yung impact nun eh. So if they're not appropriate for therapy work, maybe there are different jobs that are more appropriate for them. And so for us lang, because kasi when we say like therapy dog, we want to make sure na nakapasok yung standards natin, because sila as a therapy dog, as a human animal team, it is a service that you offer. And just like other, mental health services, we want those services to reach a certain standard, so that we make sure that everyone is safe and cared for.
Okay. So for the interest of time, Doc Ginger, no, although marami pa naman tayong time supposedly I do have two last questions, and then there are multitudes of positive comments, which I will be reading in a breeze later on. But the last two questions are, one is coming from Clarice Valencia. Have you considered partnering with Kite Foundation that offers child life therapy that can be another form of therapy that can be offered during the hospital visit? So that's from Miss Clarice Valencia.
Thank you very much. So this is, of course, always ano, in our considerations, no. It would be like a dream to be able to do this. Some of the barriers lang we encountered, number one, is of course, since these are patients with cancer, they're immunocompromised, no. So again, when we talk about like infection control and ganon, managing the risks, that's like number one in the top of mind. So far we actually had one institution who reached out to us for a potential collaboration, and they serve patients with cancer, but we haven't really finalized that yet, because on our end nga, we want to make sure that all of the protocols are there, it is clear, and we want to make sure that the humans are trained, no. But it is definitely something that is of great potential that we hope we can do in the future. So yes, hospital visits, hopefully very, very soon na patients talaga. But yun nga, magandang start na yun kay Olive kasi yun, first time na patients within a hospital setting yan eh.
Yan. And the last question before I read the comments is coming from, wait lang po ha. Scroll lang ako ng konti. From Manda Guillam. So I'm interested in supporting communities, but I am unable to serve as an animal handler. Are there other volunteer roles available?
Thank you. Yes, like, lagi namin iniisip niya na parang how do other people contribute even if you're not a handler. So ako personally, I am not a handler, no? I don't have a therapy animal. And I work with people who have other therapy animals, no. So it's a little bit tricky, but you know, we're trying to, not tricky pala, we're still trying to strengthen our programs for stewards, no. Yun yung mga people without a dog who want to participate. But as a steward, there are a lot of things that you can do actually in terms of providing support to the handler and actually running the programs. So for example, well, if you're a mental health professional, that's something that we can offer talaga. But even if you're not a mental health professional, as long as you have the training to offer some of these programs, kaya natin gawin yan. And that's what we've been trying to do right now. One thing siguro I also like to share, we're working on a children's book. This is something that's related to animals, but it's a mental health workbook. So that's the goal of that is that's something to be used by a non-specialist, and you don't need a dog because you have the book. So we have materials that bank on the human-animal bond that will not actually require animals, no? And minsan, what happens is that the participants, gusto nila actually dalhin yung animals nila. So there is like room to explore that. But yes, please do reach out to us, to communities, and let's explore how we can work together. Thank you, Manda.
And okay, so we're done with questions. I'll be just reading some of the comments ng mabilis po na before we go on to the next part of our program. So from Dr. Teresa Rosalie Del Valle, our Chief of Petro, congratulations, Doc Ginger, for your monumental initiatives in NCMH. Thank you for the significance and the impact of your contribution to mental health, and looking forward to further collaboration with you. Wag po kayo mag-alala, Doktora. Doc Ginger will stay in NCMH. Ayan po, no? And we'll be mentoring a lot of residents as well as the research and producing innovative programs with us. Yan. From Rohani, thank you. Thank you for leading this initiative. Similar congratulations from Sir Aldrin of the Mental Health Division. Sir Richie as well, thank you and congratulations for all the work, and as well as your team. Looking forward for more partnership with you. From Miss Raquel, thank you so much. Such a cute and super on-point answer on question. Napakagaling. And from Sir or from Jess Espanto, thank you for your work. Doc Ginger, more power to you and the team. Dr. Sibileha of our research team, congratulations, Doc Ginger and NCMH. Miss Nicole Isguera is also congratulating you and NCMH as well for this effort in supporting those in needs. And hats off to NCMH for spearheading the program. And of course, with PCHRD and DOST Balik Scientist program po, no? May it inspire other hospital or healthcare facilities as well to do the same. And deep appreciation to the dedicated doctors and the entire community team for their incredible work. So similar greetings from Miss Daniel Pareño. Congratulations to Ginger, NCMH and Communities. From Kimberly Ching, from Doc Olive. Ayan, thank you for your guidance now and patience. And ayan, from Liz Caro Alquiros, from Kamski, Charlene, and just Tony. So thanks for your presentation. It's a big challenge for us in the Catholic Church to respond to it as a priest. So may pahabol na comment. From Melanio C, thank you. And from Manda, of course, thank you very much. So as much as we would like to read pa po, no, yung mga susunod din yung comment, which we deeply appreciate, no, as a form of your appreciation as well to this presentation, we have to move forward to our part or the next part of our program, which is a response from the PCHRD and the awarding of certificates. So the PCHRD has sent Ms. Lucila Roja, the Supervising Science Research Specialist of the Philippine Council for Health Research and Development. And I will be playing or sharing the video presentation or the response coming from her. So i-share ko lang po siya for a while.
To the Medical Center Chief 2 of the National Center for Mental Health, Dr. Noel B. Reyes, Chief of Office for Special Concerns and Medical Specialist for Dr. Rodney Moncajes, the focal person of this engagement. Dr. Robert Roy Mapa, Chief Medical Professional Staff of Hospital Service, Dr. Beverly Azucena, our esteemed Balik scientist, Dr. Caroline May Ramirez, colleagues from the OST, and to everyone from the science and research community joining us today. Good morning to all of you. The Balik Scientist program of the Department of Science and Technology serves as a bridge for Filipino experts across the globe to return and contribute their expertise to national progress. Through this initiative, we strengthen the country's research, innovation, and healthcare capacity by harnessing specialized knowledge that advances various scientific and technological. A remarkable contribution to BSP is the engagement of Dr. Caroline May Ramirez at the National Center for Mental Health. Through her stint, she has been instrumental in enhancing mental health interventions, establishing a national suicide surveillance system, pioneering animal-assisted therapy for trauma survivors. Her efforts have not only expanded the scope of mental health services, but also laid the groundwork for evidence-based policies and innovative therapeutic approaches in the country. One of her most significant contributions was the institutionalization of the National Surveillance System for Suicide Attempts and Self-Harm. Working closely with NCMH leadership, the Department of Health, and key hospital units, she helped design a standardized data collection system to monitor suicide-related cases. She facilitated its integration into electronic medical records, ensuring it aligns with the broader mental health research information system. Additionally, she trained psychiatry residents and frontline healthcare workers in implementing suicide risk assessment tools and safety planning protocols. Her extensive work in this field also includes analyzing national suicide trends, with findings currently being prepared for publication in the Cambridge Prisms Journal special issue on suicide prevention. Beyond suicide research, Dr. Ramirez pioneered the expansion of animal-assisted interventions as a complementary approach to mental health treatment. Through the project pioneering animal-assisted therapy for adolescent trauma survivors in the Philippines, she led the development and pilot implementation of AAT modules tailored for trauma survivors. Her efforts also extended to forging partnerships with shelters and advocacy groups, ensuring broader access to animal-assisted therapy. Recognizing the importance of ethical and structured implementation, she initiated the development of national guidelines for AAI in healthcare settings and led focus group discussions with key experts to establish standards for emotional support animals in mental health facilities. Dr. Ramirez further contributed to global mental health research, particularly in child and adolescent mental health in middle-income countries, collaborating on a scoping review commissioned by the Lancet Regional Health Western Pacific. She actively mentored psychiatrists, psychiatry residents, and graduate students, providing expert guidance in research design, manuscript writing, and policy development. Her mentorship has empowered emerging mental health professionals to develop, refine, and publish their work, ensuring that future leaders continue advancing mental health research and interventions. We extend our deepest gratitude to Dr. Caroline May Ramirez for her dedication, expertise, and significant contributions to strengthening the country's mental health landscape have led to systematic suicide prevention strategies, groundbreaking research, and institutionalization of innovative mental health interventions. We also acknowledge the National Center for Mental Health for its invaluable support and collaboration throughout her engagement. The institution's commitment to research, innovation, and evidence-based mental health policies has played a crucial role in ensuring the sustainability of her initiatives. As a token of our appreciation, let me present this certificate to our Balik scientists. The certificate reads, the Department of Science and Technology and the Philippine Council for Health Research and Development present the Certificate of Appreciation to Dr. Caroline May Ramirez in grateful acknowledgement and sincere appreciation for sharing her time, expertise, and valuable service under the Balik Scientist Program short-term category, administered by the Philippine Council for Health Research and Development, given on the 14th day of March 2025 via Zoom teleconference. Signed by Leia J. Buendia, Undersecretary for Research and Development, and Jaime C. Montoya, Executive Director of the OST PCHR. Moving forward, we are confident that Dr. Ramirez will continue to influence national mental health policies, research, and interventions. We look, we look forward to sustained collaborations between NCMH, the scientific community, and international partners, ensuring that suicide prevention efforts and mental health innovations in the Philippines remain at the forefront of public health. Lagit lagi para sa bayan, balik puso, balik Pilipinas, balik science. Maraming salamat po at mabuhay tayong lahat.
Okay, maraming salamat po kay Ma'am Roha, ang ating supervising SRS or Science Research Specialist ng PCHRD para sa pagkilala kay Doc Ginger. So, similarly po, habang naandito pa rin ang ating si Dr. Azucena at si Dr. Reyes, ang ating Medical Center Chief, we would also like to acknowledge the effort and the partnership between PCHRD or DOST Balik Scientist Program and NCMH and Doc Ginger Ramirez. So, for a while po, no, yan, ipupull out ko lang yung certificate. We would also like to present a certificate of appreciation to first to Dr. Ginger. Sorry, wait lang po. Ayaw ma-share ng aking slide. Teka lang po ha. Yan, patapos na po tayo. Huwag po kayong mag-alala. Nagkakaroon na ng konting technical difficulties. Ayun, wait lang po. Ito na. Okay, as a response po sa recognition ng PCHRD kay Doc Ginger, we are also presenting the Certificate of Appreciation to Dr. Caroline May Ginger Ramirez as a Balik Scientist Program awardee hosted by NCMH in the grateful recognition of her outstanding commitment and invaluable contribution to advancing mental health research. Her initiatives have significantly enriched the understanding of mental health, fostering innovation, and inspiring progress in the field. So your dedication to this important work has made an impact on the lives of not only of the service users, but also of healthcare providers. It also promotes awareness and care for mental health within NCMH and beyond. So given this 14th day of March 2025 during the exit report of Dr. Ramirez, signed by no other than our Medical Center Chief 2, Dr. Noel V. Reyes. A similar appreciation po is being provided or given to the OST Balik Scientist Program in grateful recognition of their invaluable partnership and collaboration in advancing research initiatives which have significantly contributed to the improvement of mental health data and services and the shared pursuit of knowledge and innovation. So their dedication and support have been integral to the success of our endeavors, inspiring progress and meaningful contributions, not only to NCMH, but also to mental health in general. So given this 14th day of March 2025, during the exit presentation of Dr. Ramirez, signed by no other than our Medical Center Chief to Dr. Noel V. Reyes. So before we go to our closing remarks po, I would like to thank as well the following individuals who have been very instrumental in this kind of partnership with the OST and the Balik Scientist Program. So we would like to thank Dr. Lea Buendia, the Undersecretary for Research and Development of the Department of Science and Technology. Also, to Dr. Bernardo N. Cepeda, the Executive Director of the National Research Council of the Philippines under the OST. Dr. Jaime C. Montoya, Dr. Montoya, the Executive Director 3 of the Philippine Council for Health Research and Development of the OST. And similar appreciation to Ms. Joanna A. America, the Chief Institution Development Division of the PCHRD. Mr. Paul Ernest N. De Leon, the Chief Research and Development Management Division of PCHRD, Ms. Yulian C. Garcia, the Chief of the Research Information Communication and Utilization Division of PCHRD, and last but not the least to Ms. Michelle V. Atienza, the Chief of the Finance and Administration Division of the PCHRD. Okay. So with that po, we now are going to the last leg of our program, which is in the closing remark. So this closing remark will be provided to us by no other than the Chief of the Medical Professional Staff 2 of the Hospital Service of the National Center for Mental Health, Dr. Beverly A. Azucena.
To our Medical Center Chief, Dr. Noel Reyes, the representative of PCHRD, PCHRD, Ms. Roja, all of you present in this activity, good morning to all. No? So certainly this activity has brought in a robust a type of learnings and insights, no? And as stated by our NCC, it is in keeping to our directive to craft and develop new interventions to upscale mental health services. And this achievement is one of the first, or is actually the first, to be presented in public. Our thanks to our Balik scientist, Dr. Ginger Ramirez, for choosing mental health as the field of her work, no? And for choosing also the National Center for Mental Health as her venue to unfold this innovative concept and intervention. And of course, and a personal tone for carrying on the ideals of community health. No? So we would want to express equally our thanks to the DOST, PCHRD for their support in this project, and to our Medical Center Chief and the Office of the Special Concerns for the warm reception for this undertaking. So, Dr. Ginger Ramirez, congratulations not only for this extensive discussion, but for a far-reaching work that you have done and you plan to do. And to everyone here today, thank you for your presence, and may this presentation inspire all of you to help the National Center for Mental Health to sustain and develop more interventions to promote mental health advancement. So thank you and good morning.
Maraming salamat po, Doktora Azucena. So, dito na po tayo sa end ng ating presentation, exit report presentation of Dr. Ginger Ramirez. So, before we end po, we would like to invite everyone for a photo opportunity. No? We really thank all of you. No? We have at least 80 participants kanina or more who have joined us. And we are very appreciative of your time. No? 9 o'clock to 11, nagstay po kayo. With that, deserve natin na mag-picture. So maybe for those who can open their camera later, pwede na tayo mag-open ng camera. Teka lang, mag-set ako ng sige po. Ayan. Okay. So kami po muna ang mga nasa panelist. Tignan natin makakapag-open. Okay, 1, 2, si Edward, si Doc Reyes, maybe in the meeting na siguro. No? Pero no worry, Doc, we understand. So, okay. So I'll be taking pictures now in 3, 2, 1. Okay, thank you very much. Doc, yung mga participants ba natin makapagpa-picture din sila or because naka-attendee mode sila, hindi yata sila makaka-join, no? Sige, sorry po. Pero we really appreciate all the efforts and the time that you have provided to us. And of course, the positive response from our audience and similarly, their interest in asking questions. Sasagot naman po natin lahat. So with that po, maraming salamat po. This ends now our exit report presentation of Dr. Ginger Ramirez. Have a nice weekend ahead po. Maraming salamat po sa inyong lahat. And we look forward to other similar activities like this one. And we will be inviting, of course, the public for this. Thank you very much po and ingat po tayong lahat.